This is Stanford Engineering's The Future of Everything, and I'm your host, Russ Altman. AI promises to improve healthcare in many ways. Already, we are seeing robotic surgeries that use AI for guidance and planning. We see AI analyzing X-rays, MRIs, and CTs to more sensitively detect abnormalities, and we see promising systems that can look at skin and recognize skin cancer. But most of us have not seen AI in our own care because our primary care physicians don't have access to AI algorithms that help them yet. This is ironic because primary care visits to physicians account for more than half of all visits. And there are plenty of opportunities to use AI to make practices more efficient, predict new diagnoses, and optimize resource utilization. It also helps provide information to patients about their new disease or their new medications. Steven Lin is a professor of medicine and primary care at Stanford University. He thinks and writes about technology and innovation and how they can impact medical care. He is particularly interested in making sure that promising technologies make it all the way to the bedside and don't get caught up in the process. So Steven, thanks very much for coming today. We hear about AI in medicine all the time, but you have a kind of a different perspective, which is that a lot of the AI we're hearing about is really for the super specialized delivery of medicine, and that there's a huge opportunity in other parts of what you might call regular medicine. So tell me how you got to that, and what do you think is the big promise of AI for medical care?
Yeah. Thank you. First of all, it's an honor to be on. Thank you so much. I'm so happy to be speaking with you, Russ. You're exactly right. If you take a look at the landscape of healthcare AI today, you realize that the vast majority of the innovations, the investments are happening in the inpatient, that is the hospital-based care space, which actually only represents about 4% of all care delivered in the US. Now, by contrast, primary care, that's the care that you get by going to your family physician, your internist, or your pediatrician. That represents 52% of all care delivered in the US, more than all other specialties combined. But that area of medicine is completely being left behind in the healthcare AI revolution. And I'm worried about the implications of that for our society and for healthcare in the future.
Great. So let me ask, what are the capabilities that you've noticed? Like, what can AI do now that you see as potentially impactful in that 52% of primary care settings? You might imagine that people think, well, you're just talking to your doctor. It's not very complicated. We don't really need AI. I suspect you disagree with that.
I think there are a variety of use cases. I'll just maybe mention one to start, and then if we have time, we can talk about more. But AI is getting really good at prediction. So we have predictive models now, for example, in the inpatient space for things like sepsis detection. Well, the same type of technology can be applied at the primary care and population level for predicting avoidable healthcare utilization. So think preventable ER visits or hospitalizations for conditions that are called ambulatory care sensitive conditions. So these are illnesses that if you can get treated well in primary care, you will never end up in the ED or in the hospital. Hypertension, diabetes, heart failure. If we can apply the same amount of investment and energy that we currently do to the primary care and population health space, say, for example, in predictive modeling, we can then save perhaps $100 billion a year in preventable hospitalization costs to the healthcare system.
So one of the things about the hospital care that I know, as you know, I'm a bit of a internal medicine doctor, is that there's a lot of data collected in the hospital. Is there evidence that we have enough data from the primary care interactions to kind of build the kind of models? I think everybody has heard that these AI models are very data hungry. They need a lot of data to appear before they start appearing intelligent. Are you thinking that we now have enough of this data available, or is collecting the data part of the challenge?
I think collecting the data is part of the challenge. To me, the issue is not with the total volume of data. As I mentioned, the vast majority of care being provided is being done outside of the hospital in the primary care space. I think it's more about the time horizon of the data. So in the hospital, you're getting vital signs checked every couple of hours. You have labs drawn every couple of hours. You have an enormous amount of data in a short amount of time. It's actually the kind of the opposite for primary care and population health. You have more unique individual data, but each of those timeframes are much, much longer. You're talking about months. Every couple of months you have a visit, or every couple of years you have a visit. So I think the issue here is how do you both make predictions using that kind of long-term data, and how do you supplement it with maybe more short-term data that can shorten the time horizon for predictions? And I think one of the more, exciting innovations in this front is combining things like remote patient monitoring data, think wearable technologies, for example, that can feed in more real-time data into these predictive models for population health. And then I would say the other big challenge is, of course, interoperability. So when you're talking about a population health data collection, getting all of the data that people are depositing in different EHRs and health systems is going to be a major challenge.
And just to make sure I understand, is it partially because people have fragmented records? You visit a doctor, you have different insurance, then the two insurance companies need to get their data together. Your new doctor needs to look at the data from your old doctor and merge that, all that kind of stuff.
That's exactly right. Data is absolutely fragmented across systems, across EHR vendors, and we don't yet have a really good way of getting all of that data together. But if we could, then I think the ability to harness that outpatient data is tremendous.
So I wonder, so somebody listening to our conversation might get worried about, because there's also been AI in the news, being a source of bias, violating privacy. So to keep this, and I know that that's not your goal, you're a doctor, you just want to help your patients. So maybe paint a picture of some of the areas. You already said one is the healthcare utilization and making sure that we pick people up early when they have pending problems. Can you give a sense of some of the other high impact AI applications that you've written about and that you imagine could really move the needle on people's individual health?
Yeah, there's a lot. Everything from improving diagnostic excellence at the bedside to predictions, as I mentioned. But actually, what I'm really excited about too is some of the "quote unquote" less sexy applications of AI usage that can actually really benefit care.
Less sexy. I love it.
Yeah, exactly. So that's actually kind of the practice management, reducing burden of clinical documentation, improving the way that we're efficiently delivering care right now. As many of your viewers might know, a lot of American healthcare costs are wasted on overhead and clerical inefficiency. And so for every 1 hour the average physician is spending in front of patients delivering clinical care nowadays, we spend another 2 hours doing work in front of the computer that's completely clerical, right? A lot of it is just documentation. A lot of it is billing and coding. AI is actually really good at automating things like that. And in my opinion, that's actually a relatively low-risk area of applying technology today that is really good at doing stuff like that without venturing into more of the higher risk, higher ethical, potential ethical issues that we think about when we think about diagnosis, for example.
So let's dive into that, because that sounds really good. So you're talking about support of the almost like the logistics of the medical care system, and like I can imagine pre-visit and post-visit. So when I think about pre-visit, I know as a physician that people not showing up for their appointments can be very, it can be a big waste of time, and so I could imagine maybe AI can help in getting people reminders and predicting how many people are going to actually show up. It's a rainy day and or it's a beautiful day, nobody wants to go to the doctor. And then post appointment, you could imagine that, yes, there's all these things about writing a note. What did the patient report? Are those systems, do they exist yet, or are they still a dream for Steven and Russ?
Pieces of that system exist. So, for example, for clinical documentation, there's actually a whole bunch of companies now with voice-enabled digital scribes. So think microphones, wall-mounted devices, smartphone devices that use natural language processing to capture the conversation in real time and then provide a clinical document for that provider. Those exist, and they're getting better and better every day. So that's helpful. And then there are also companies that focus exclusively on the back office procedures that we think about: billing, coding, administrative processing, quality reporting, all of those things. So
right. So people who are not in the profession might not know that at the end of your interaction with a patient, a physician has to figure out all the relevant diagnoses that were discussed during the visit, how much time was spent on each one, was the appropriate physical examination and history and physical. And so, yes, when you say that, it's very easy for me to imagine that a system that understood English, and we all know that Siri and Alexa and all of these digital assistants are getting very good at listening, could be very helpful at saying, you know what, you discussed diabetes, arthritis of the knee, and mental health. And that would be a huge help potential. And those are the kinds of systems that you're imagining?
Yeah, exactly. Studies have shown that all of these non-clinical clerical burdens that are plaguing doctors and practices today probably cost upwards of more than $100 billion a year to the U.S. healthcare system. And more importantly, I think, it takes the doctor away from the patients in front of them. Right. So if you're a patient, and all of us are, you would rather your doctor spend all their energies on you and other people that they're serving and not on doing paperwork.
Really makes sense. So you had mentioned the great opportunities for like listening and scribing, and I happen to know that you've written about something called conversational AI and its promise for medicine. It's not quite the same, but it's a really interesting idea. Can you tell us what's conversational AI and what role could it play, especially in the stuff we've been just talking about?
Yeah, absolutely. So think about the voice assistants that are present on your phone today. Your Siri, your Alexa, your Google Assistant, your Cortana. It's the same type of technology using natural language processing, but adapted for use cases in healthcare. So this can be from anywhere from medical advice and triage. So let's say you experience symptoms, you don't know if this is important enough for you to visit your doctor. You're calling in and you speak with a chatbot instead of a nurse, for example, that can triage your concerns. That's one example. Or maybe you're actually doing a pre-visit and you're speaking with a chatbot that's taking your history, starting to provide sort of a differential diagnosis or generating and pre-prepping that note for that provider so that when you go see that provider, you have a more efficient visit. Technology like that exists today, but it's not widely used, widely implemented, and we still don't really know what the potential negative implications might be. But I think it's a really worthy area of investigation.
I totally agree. In my area of specialty, which is drugs, people are always interested in what are the side effects of this drug? Will it interact with my other drugs? And I see a great opportunity because for those kinds of questions, they're not particularly sensitive. And patients would love to be able to say to their phone, hey, I feel sick to my stomach. Is that a side effect of my new medication?
Absolutely. That's something that we can definitely feel, I think, quite confident to let a machine take over. There's actually also really interesting studies to say that in certain circumstances, patients actually feel a little bit more comfortable speaking to a machine and are a little bit more truthful in speaking with the machine than with their providers for certain types of sensitive topics. So we might intuitively feel like people don't want to speak to chatbots, but there are instances where I think it could be really helpful to provide greater access to care for that first initial contact for a lot of things that don't require a clinician. But then also in certain areas, people might actually feel better.
This is The Future of Everything with Russ Altman. More with Steven Lin. This is The Future of Everything. I'm Russ Altman, and I'm speaking with Professor Steven Lin of Stanford University. In the last segment, we discussed the promise of AI for primary care and some of the applications that are emerging to improve the quality of primary medical care. In the next part of the conversation, Steven will describe an emerging discipline called implementation science. It studies how to take a new technology and introduce it into healthcare or any other setting without disrupting the professional workflows of busy professionals, and in this case, busy doctors and nurses. He will tell us that the widespread uptake of electronic medical records over the last 20 years was not always a positive experience for physicians, and so they're nervous about the introduction of AI. Nonetheless, he is optimistic that we have now learned those lessons and it will enable us to introduce AI into healthcare in a more successful way that improves the health of patients. So Stephen, you've really painted some great pictures of where AI in several places can help. But we have to get from here to there. And I know that there's this field of implementation science. So tell us what that is and why it's so important to kind of implementing your vision of how AI can help in primary care.
Yeah, absolutely. So one of the biggest problems right now in the field of healthcare AI is that 90% or more of all AI algorithms never make it to production. That means they're developed, they actually work really well in retrospective studies of performance, but they never make it to the bedside to benefit a single patient or a single clinician. And I think that's a shame. One of the biggest reasons for that is because we haven't, as a field yet, learned how to focus on the implementation science of AI. It's a very nascent part of healthcare AI as a discipline in general. Now that we have these algorithms that work really well, the next step is to figure out how they will work in the complex healthcare environments in which they are intended to function. And that is a very tall task.
Gotcha. So I can imagine a zillion issues in why something might work. You write a paper about it, it looks promising, and it's never adopted. So can you break down for me what are the elements of implementation science? I'm sure part of it is things like who gets paid, but I'm sure there's also things about I'm a busy physician or clinician or nurse, and if you want me to use this system, it cannot disrupt my life. So tell me how you break up and how you think about all these multi-factors when you're figuring out how to go from a promising system to something that's used every day.
Yeah, one way to look at it, Russ, is to think about, well, actually, we've had AI systems to help with clinical decision support all the way back in the 1970s to 80s. So we had Mycin, we had Athena. These are algorithms that were developed to treat hypertension, for example, and manage bacterial infections, and they were intended for primary care. But most people who weren't born in the 70s or 80s might not even know that they existed. And that's because they were never implemented and never adopted. But they work. So why is that? Well, one of the big issues, we think, is that those systems created too much friction trying to integrate into existing human-driven processes of care. Yeah. Because they existed as standalone systems that didn't integrate into the way that doctors practice. Another big problem was the lack of alignment and incentives to drive adoption. So I think today things are a little bit different. We have now EHRs that serve as systems for integration.
Electronic health records, yeah.
Electronic health records, exactly. We have shifting alignment and changing financial incentives driven largely by the transition from fee-for-service or volume-based care into value-based care, which makes it very different, for example, for primary care and population health to have a reason to adopt these types of tools. And so that is one aspect of implementation science. How do you input these tools into the existing processes of care to make it frictionless so that doctors will actually want to use it? And then also the larger macro alignment and financial incentives that really drive adoption and use.
Who does this implementation science? It doesn't strike me as something that a doctor is trained to do, at least in their standard training. And the engineers and the innovators who come up with the algorithms may or may not be interested and able to bring them to full fruition. So who does the implementation science?
Yeah, there's an entire field of scientific inquiry that's just implementation. People who study how things work in various settings. In the healthcare sector, the experts here are what we call quality improvement experts. So these are individuals who are usually not clinicians, but they're trained in the methodologies of improvement. So they'll take a look at a given process or a given workflow or a given care pathway, identify the areas where there is friction and try to reduce it. And so that's so important because healthcare is one of the most complex ecosystems that exists today. And every single health system looks a little bit different. So these quality improvement experts are really helpful, I think, in working with the clinicians and also with the technologists. And I think you need those three legs of the stool in order to drive the field forward.
And quality improvement folks, are they typically employees of the healthcare system, or are they consultants, or do they come from the companies that are introducing the technologies? Where do they who pays their bills?
In many health systems, for example, like at Stanford, they are employees of the health system. In other health systems, they might be external consultants. But most health systems now, if they have any sort of focus on driving quality and improving care, they will have some sort of quality improvement mechanism, which is actually really helpful because I think that's the mechanism that we should be tapping into as we start to think about how to implement these products in the actual care setting.
So let me ask you, let's think about the clinician perspective. As you said, one of the key things for the implementation science is to make sure that it doesn't disrupt the life and the workflow of these busy humans who are trying to deliver care. What have you seen as the attitude of your colleagues? Now, you are an enthusiast. I'm not going to count, even though you're a physician, you're also a specialist in technology and innovation. So I'm going to guess that you're psyched about all of this. What is the feeling that out on the street among regular physicians who are practicing every day? Do they look forward to this? Are they trepidation, or is it some kind of combination?
It's some kind of combination, but if I have to say that the prevalent mood, I think, is one of trepidation. And I don't blame them because as physicians, we were kind of screwed over by the EHR revolution, right?
And why do you say that?
If you take a look at all of the relevant studies on physician attitudes towards electronic health records, if you look at all of the relevant studies when it comes to burnout and professional fulfillment when it comes to the healthcare sector, it is very, very clear that dissatisfaction with the EHR is one of the main drivers of why physicians are burning out and leaving the practice altogether.
Wow.
So this is a pretty big issue. And there's a lot of really smart people that have written a lot of postmortems on what happened. But I think it boils down to this. Physicians were not at the table when it came to the design of these products. These products were designed for us, but without our input, and certainly not by us. And that's one of the lessons I think we should keep in mind as we head into this healthcare era with AI, which is that if we want these tools to work for us, not against us, we need to be at the table as clinicians.
Okay, so that's really useful. So going back to my question, there's trepidation, and you totally understand. In fact, it's almost like there's been one strike, and 3 strikes you're out. Maybe there's been 2 strikes. So other than the trepidation, and you're involved in this, I know that you do this kind of work. I guess what's the approach to make sure that they don't get, as you said, screwed over a second time by because they should, right? It should be improving the care of their patients and improving the quality of their professional life. I mean, I'm sure that's the goal. How do you manage them, and how do you get them on board with this then?
I think one of the things that we need to try to find a way to facilitate is bilateral conversations between the people who are developing the products and the physicians who are going to be using them, right? So let's just take primary care physicians, for example. Primary care physicians will be the single largest group of end users of healthcare AI once all is said and done in the healthcare sector. So they have the most to gain, but also the most to lose in the coming era of innovation. So they must be working with the technologists to first identify the use cases that are important to them, but then also to co-develop the technology so that it is not actually making things worse. And there are many models for how that can be done today. At Stanford, for example, my team, the Stanford Healthcare AI Applied Research Team, works very closely with technology companies to do exactly that. I think the other thing that we really need to pay attention to, though, Russ, is also the trust. aspect of things. Not just the fact that the technology developed works, but the trust that these end users, these clinicians will have in the technology. And I think what you see right now with the studies out there, just the overall mood, is that there is certainly a lack of trust. A lot of people think about AI as a black box. And for a lot of deep learning neural networks, that is true. It's very difficult for the AI to explain how it came to the conclusion that it did.
Yes.
And so, well, how do you then design systems where there's adequate explainability, adequate transparency, so that physicians will actually trust the output of those tools and be able to use it at the bedside?
So that's great. So in our final minute or so, minute and a half, tell me how this is going to roll out. When will patients start seeing this in their primary care visits? Or what are the signs that this is starting to succeed, that people who are excited about this, patients especially who feel that they can benefit, are we looking at a 20-year challenge, a 10-year challenge? You have your finger on the pulse of all this. Where are we in terms of the implementations?
Yeah. Well, first, I think we're already starting to see trickles of this technology into the bedside. I would say that in the next 5 years, we're going to see an acceleration of more of these tools that are going to be incorporated into clinical care, but in very spotty, non-coordinated ways, and probably concentrated in urban areas where a lot of this research and development is happening at the exclusion of a lot of different areas, which is a whole different problem altogether in terms of equity.
Yes.
But I think widespread adoption, I think we're probably looking at another 10 to 20 years, optimistically speaking. Again, if we had invested enough resources and time and investment into the translational part of things, into the implementation science, we might be a little further ahead. But right now, the data science is far ahead of the implementation. And unless the implementation catches up, we're not going to see these tools at the bedside. So maybe 10 to 20 years, I would say.
Thanks to Steven Lin. That was the future of AI in primary medical care. You have been listening to The Future of Everything with Russ Altman.